Good morning, everybody. This is Dr.Altamash Shaikh, and I've been given a very good task to talk about the treatment of subclinical hypothyroidism improves pregnancy outcomes or not, a perspective after my friend and colleague Dr. Deepak has already spoken on it, which is a different perspective now. So I think I will take you through this particular agenda of subclinical hypothyroidism in 2 or 3 slides. How can it affect mother and the fetus both? What are the outcomes immediately peripartum or immediately postpartum to the mother and the fetus? What are the long-term outcomes? Is there a data because we are treating, is it only for pregnancy or even beyond that? In between, we will also show you some national as well as international guidelines and their comparison of how we can best make a use of all these data to treat our patients and to make them better and happy. Also some updates about fresh studies about which came in 2019 and 2020, which just came very recently. Some futuristic trials about what could be done and about some research which is so important for this particular topic of subclinical hypothyroidism. And we will also divide it into pregnancy, infertility versus a normal pregnancy and unassisted reproductive technique pregnancy. So I think here we go with some few basic slides on physiology and on prevalence that yes, as per a lot of studies we have, when you take the cutoffs of 2.5 to 3, then a large population, around 1/3 to nearly less than half of the population is having TSH cutoff in this particular study of around 11 studies in around 9 subsections across the country which were done, and hypothyroidism and also subclinical hypothyroidism was in this much high prevalence, which means that we need to understand about how do we go about it. And once we've understood the physiology where TSH is the mirror image of HCG, and that this is kind of a stressful situation even for the thyroid, or a stress test for the thyroid, that is how the pregnancy is called, we would also understand that the neonatal functioning of thyroid happens or starts functioning only by around 10 to 12 weeks. However, the demand of E3T4 is by around 30 to 50%. And there are functions of these hormones in various aspects of the growing fetus and also to continue and maintain the pregnancy. So we had these guidelines from our own country about thyroid dysfunction during pregnancy, and it did give us for a lot of views and a good perspective about already existing issues. And however, they've been also revised as thyroid dysfunction in pregnancy with 2019, and which talk to us about a lot of issues. I will try to focus only on the subclinical hypothyroidism, where one meta-analysis also had shown that around 50% of pregnant women can be missed depending upon if only the case-based screening was taken. So that screening, when we understand and you've done the screening universally and now your patient is having subclinical hypothyroidism, so what would you do? So first thing that we keep in mind that the targets are 2.5, 3 and 3 depending on whether you follow the Indian guideline or the ETA or the ATA, which talks about upper reference limit as 4, which came in 2017. However, our ITS and FOXY guideline talked about the 2.5, 3 and 3 for first, second and third trimester. So complications are many if it is untreated for both maternal, fetal as well as in the neonatal period, as you look at the 3 columns in this particular slide, and that both subclinical and overt need to be treated for good outcome. And now we will show about some more data on the delivery rate, on the pregnancy loss, and on a successful delivery in subclinical hypothyroidism with its outcome. In untreated women, there can be placental abruption, there could be preterm birth or preterm delivery. And one review also showed that there were multiple adverse maternal as well as neonatal events, as you see in the first column here on your left, with loss of pregnancy to labor to preterm delivery. There were even higher incidences and chances of gestational hypertension, and the long list which has been shown over here already. Now, the effect of therapy and loss rate were also studied in two particular recent studies and review, which was by Nazarpour in 2018 and by Rao et al., which came in Human Reproductive Update in 2019. And that it showed, the first study showed that if the TSH is more than 4 and TPO antibody was negative, the rate of delivery in thyroxine treated women compared to those not receiving treatment was significantly lower, which means that the treatment was beneficial in this particular study in these categories. Also, when you look at the systematic review, the loss of pregnancy or the preterm birth were significantly reduced in women who were pregnant and had subclinical hypothyroidism, whether in both the categories, whether they had autoimmune thyroid disease or not, which means even if TPO was negative in this, according to this particular review, the pregnancy loss and preterm birth was completely and significantly reduced with supplementation. I will talk about this review in detail in the next coming slides, where we are going to talk about more evidence where it also shows that there are lower chances of pregnancy loss and higher chances of live birth rate, which is also we look at it compared to placebo and versus the thyroxine treatment given. Also, in one more study which came in 2019, infertile women had highest issues with ovulatory dysfunction, where they also had thyroid autoimmunity or TPO positivity as one of the important issues in them, and that there was a potential reduction in miscarriage rate. So supplementation in these category of patients, especially infertility or a TPO positivity, along with either a BOH in that category, also it does help, and it should be emphasized that screening should be done at immediately at the first visit. Management point of view for subclinical hypothyroidism is important to understand, because it is the management of thyroxine that you give as per the body weight doses which only gives you the outcome. So there are two important guideline and studies. The guideline I'll talk to you right now, and the study I will talk to you towards the end when I talk to you about the futuristic and the research part, how the dosing is important. So usually the target should be less than 2.5 or so, and or if there is a pre-existing subclinical, already the patient is on treatment, then we would give 30% as the dose, which could be increased, or with pre-existing overt hypothyroidism. And we would also want to understand that the dose has to be given in such a way that the pregnant lady does not fall into category of hyperthyroidism, or there is no iatrogenic palpitations and others. So if I have to take you through two cases before I give you those update slides, let's take two patients, Mrs. ABC and Mrs. XYZ. Here, this is a 6 weeks pregnant lady with a routine antenatal checkup of TSH of 3.6 with normal T4, no family history, no thyroid disease in the past, no bad obstetric history, and there is no goiter, no other signs of hypothyroidism. TSH is in between the category of 2.5 to 4. In this scenario, what is the further line of management, or what are the possible things that we could do? Anybody? I don't know, there's an option of raising hand in this particular software, but however, I'll show you the next slide. Treat with thyroxine, or would you want to evaluate for TPO antibodies, or you don't want to do any intervention at all? So we will show you the evidences with all the three particular options. Whoever is selected can concentrate on those particular slides. Now this one talks about if you are not managing, once again, it shows a long list of loss of pregnancy, preterm labor, whether it's IUGR, low birth weight, if these are untreated, versus if the patient had euthyroidism, or where the TSH was normal. Now, effect of thyroxine supplementation in one more systematic review showed that it favored thyroxine in terms of the outcomes, and it was better. So the intervention was favored as per the forest plot, both in terms of preterm delivery and the abortion. and that the supplementation was better and helped in patients with TPO positivity for both loss as well as for preterm delivery. And that this meta-analysis confirmed the beneficial effects of LT4 supplementation, namely the reduced risk of both the things among patients with among patients of subclinical hypothyroidism with or without autoimmunity. And nearly the same was told by the ATA in 2017, what the systematic review is confirming. Although in 17, the consideration was weak, however, they might change in future as we have too many systematic reviews coming for the same. One more case before we move ahead. Mrs. ABC, 31 years, a lady, married 5 years, primary infertility, known case of PCOS, 3 cycles of intrauterine insemination done and it did not work out for her. PSH is now 4, FT4 is normal, plan for IVF, and I'm sure all the hands would be raised that yes, this patient should be treated now for history of the above complaints. Now, in these people, those who are undergoing ART or assisted reproductive technologies, there was one meta-analysis again, which took the most famous studies of Negro, Kim, and Rehman, and told about that the ranges of TSH, and that it actually concluded supplementation of thyroxine to improve the pregnancy clinical outcome and clinical outcome in women with subclinical hypothyroidism, whether they had autoimmunity, if they are undergoing ART, it should be treated. So I think the perspective about treating all the patient versus talking when we have the data about the outcome and we are doing does make more sense to understand. And this is how we can even talk and counsel our patients that there is a data even in patients undergoing IVF or ICSI or any other ART that we would do for our patients with infertility. Another updated meta-analysis which also came in reproductive bio and endocrinology was in favor of the therapy. If you look at the total events and LT4 or the thyroxine supplementation, and that given its potential to reduce the miscarriage, thyroxine supplementation for infertile women should be given to people undergoing TSH, which is more than 2.5, and the same was reiterated with the ATA guideline, where a goal in even ART patient was to keep it less than 2.5. So this was one of those, after the Cochrane review, we were trying to search, has there any trial which are ongoing? So at the moment, trials are not looking in 2020. This was just researched today, and we have not found out any new studies which are trying to look at it, which actually looks at the perspective and makes us talk more confidently that currently there are no studies looking at the same question, and they're looking at either iodine supplementation with autoimmune disorder, or they are looking at thyroid dysfunction and psychomotor development, or they are looking for the range. But however, treatment-wise or outcome-wise, currently in the last 1 year, there are no studies which are recruiting. And also, I want you to understand one more thing before I finish with my next slide. I don't know how many minutes I have left, but I think I would quickly finish. There was one study which came in around last decade, around 9 years back, as CATS1, which was published, and it made a lot of noise about suboptimal gestational thyroid dysfunction, SG thyroid function, SGTF, and it talked about that they should be supplemented versus they should not be supplemented, and it compared these women in pregnancy with suboptimal function versus the normal gestational thyroid function. And now after 9 years, they gave a second follow-up, which just got published recently in this year itself, but they have labeled it as a CATS2 study. And here they say that women, those who were supplemented, had lesser BMI, had better outcome even at the age of, even after 9 years of, after supplementation when it was done. So it's a long-term follow-up, and it also changes our perspective that yes, it does help and that they should be treated judiciously. However, a word of caution that look at the dose that we are trying to give the pregnant lady, and we should not be overdosing them at all, and that we need to spend time about the tablet hygiene and explaining it to them how to take the tablet, not to miss the tablet, and not to even miss the tablet, or look at the labeling properly and take the correct dose. Do not miss out on the name of the pharmaceutical preparation. Take the same thing throughout pregnancy and later also, so that the bioavailability issues are also taken off, and they can then get still better outcomes, because these are those clinical things which are important and can be taken to understand from there. And I think I would like to stop here, and if there are any questions, I would take it further over to organizers. Thank you so much.